Hey there, pilot providers! Do you ever wonder why certain people cycle through the crisis system over and over again? What would it look like if we changed our strategy? Instead of stabilizing individual crises, what if we worked to stabilize individuals? Working to stabilize an individual means recognizing that a behavioral health crisis is not over in an instant. The CIP, or Crisis Intervention Protocol, does just that. The CIP is comprised of 3 stages. During the crisis, data is used to accurately identify patients who are high utilizers. Staff look beyond the immediate crisis and place more consideration on discharge planning and care coordination. After stabilization of the crisis, staff offer a real-time linkage and immediate transportation to a whole-person care-centered outpatient service. This connection assumes that the crisis is not over in an instant and allows for patients to process outside of the crisis setting. More in-depth needs assessments and linkages occur in a patient-centered, care-integrated setting. Between care, coordination occurs among providers, either in person, via email, or by phone. In addition, case conferencing occurs where patient cases are presented to a group inclusive of providers involved in the patient's care, system experts, and consumer experts. This allows for system-level learning, collaboration, and care coordination. The CIP was utilized during the John George Trust mini-pilot. Phase 1 of this pilot focused on the highest users of John George's PES. The highest utilizers were defined as individuals who had accessed John George 10 times or more between January and June 2017, a total of 49 individuals. This pilot ran between September 2017 and March 2018. Over the course of the 6-month pilot, 3/4 of those identified patients visited the PES at least once during the pilot. Thanks to the dedicated work of informed PES staff who changed their strategy by operationalizing the CIP, all of these patients were offered the option of a whole-person care-centered disposition. For those who accepted, many were linked to new services that met critical needs. So then what's next? Here's where we need your help. In Phase 2 of this pilot, we aim to reach more individuals and offer more disposition options. Instead of focusing on only the highest utilizers, we plan to also focus on individuals who are demonstrating rising risk. Rising risk individuals are those who have accessed John George 4 or more times in the past 12 months. So, what can you do? During the crisis presentation, use data to accurately identify patients who are rising risk and high utilizers. Review the crisis utilization pattern of the patient you are assessing. If a patient has had 4 crisis visits in the trailing 12 months, flag their chart as high risk and request a social work consult prior to discharge. Communicate with the patient your concern about their health. Provide psychoeducation about the importance of outpatient follow-up after a crisis. Explain your plan to consult social work. After stabilization of the crisis, social work staff offers a real-time linkage to a whole-person care-centered outpatient service. Transportation is offered to either Trust Health Center or additional disposition sites that will come on board through the course of the pilot, like community clinics offering same-day appointments, or wellness centers that offer an array of services to meet patient needs. Social work staff provides pertinent clinical history to the receiving clinic. For patients with case managers, social work staff will contact the case manager to alert them of the discharge plan, or to request the case manager suggest an alternative disposition prior to discharge. Through linkage and coordination, together we can get some of our patients with the most complex needs connected to ongoing care beyond the crisis system. Studies tell us that these linkages and follow-ups are essential to achieving better outcomes for our patients. Thank you for your partnership.